Hello everyone. So today we are back with the discussion of practice questions, and today we are going to discuss about H2 antagonists and proton pump inhibitors. So a 72 years old patient with peptic ulcer disease PUD is being treated with cimetidine. Which of the following adverse effect is more likely to occur in the patient compared to other H2 receptor antagonists? So first option is increased libido. It is wrong because it reduces libido actually. Hypertension, then it also says thrombocytopenia and confusion. So I think it should be thrombocytopenia. Let's see what is our hint. Consider the specific CNS and okay, yeah, it causes confusion. Okay, so CNS related defect is confusion and anti-androgenic profile associated with cimetidine other in older adults. So I think confusion is the one. Yes. Which of the following medications irreversibly inactivates? Irreversibly, it says, then it is lansoprazole, and it's going to block hydrogen potassium ATPase. There's just one option correct, that is lansoprazole. Straightforward question. A patient requires H. pylori eradication therapy. According to the guidelines, what is the standard dose, oral dose, for esomeprazole in our triple therapy regimen? So, patient is having H. pylori positive test. So, 20 milligram once daily, 40 milligram once daily, 40 milligram twice daily, or 20 milligram twice daily. So, I guess it's 20 milligram twice daily. In case of H. pylori, dosing is twice daily. I'm not sure about milligram, that either it is 40 or 20. So I will go. Let's ask for hint. Eradication regimen usually involve twice daily dosing of the proton pump. So I'm sure about twice daily dosing, but is it 40 or 20? I think it will not be that much vigorous treatment. So 20 milligram. Okay, 20 milligram is the right answer. Let's go next. A patient with creatinine clearance of 25 ml per minute is prescribed cimetidine for PUD. What is the maximum recommended daily dose? So it's 800 milligram daily, but clearance is less than 30, so I think its dose will be 400, means half of the dose. Oh, it's wrong, 600 milligram. I was about to take 600 milligram, but I didn't. So if clearance is between 15 to 30 ml per minute, then recommended dose will be 600 milligram daily. So first wrong answer. Regarding the use of proton pump inhibitors and H2 antagonist during pregnancy, which statement is correct according to the Australian categories provided? Okay, so nizatidine is not preferred. Rather, nizatidine comes in category B3, and B3 category means less data is available to show the safety of any drug. So first option is wrong. Omeprazole is category B1. It is actually B1, but let's have a look to other options. All proton pump inhibitors are category B1. I think so. But yeah, rabiprazole is actually B1. Yes, uh, rabiprazole is B1 and other are B3, but can still be used. Rabiprazole is highly safe in pregnancy. It is right. So the question is, when counseling a patient on the use of lansoprazole 30 milligram orally, disintegrating tablets like fast steps, what should you advise? Option A, take the medication strictly after a heavy meal. Option B, suck the tablet gently and swallow the granules whole. Option C, avoid water when taking the tablet. And option D, crush the tablet to ensure a rapid absorption. So I think all of proton pump inhibitors, yeah, you can also observe hint focus on administration method that protects the enteric coated granules. So if granules are coated, then we usually add one thing in the label, that swallow whole, do not crush. We also add the same sentence, same warning, or same instruction for those tablets which are sustained released. For example, um, Volter and 75 milligram, that is slow, sustained release. Or we also add the same warning for aspirin, enteric coated aspirin, okay, Cartia. So I would go with option B, because it says swallow the granules whole, and it's mean telling the patient, giving information that you have not to crush the granules but to swallow the granules as it is. So let's see, what does it say. It is the right answer. Question number 7 says that which H2 antagonist is most likely to be involved in drug interaction via the hepatic cytochrome P450 enzyme system? A. Famotidine, B. Nizatidine, C. Ranitidine, and D. Cimetidine. So the correct option is Cimetidine, but let me tell you that Cimetidine um, actually causes the inhibition of cytochrome P450. As a result, it has a lot of drug interaction, and that's why Cimetidine is one of the crucial drug as far as drug interactions are concerned. Question number 8. A patient is prescribed long-term proton pump inhibitor therapy for more than 1 year. According to the practice point, which of the following should be monitored? So there are some severe side effects of long-term usage of proton pump inhibitor, and the main is depletion of some vitamins like vitamin B12, that is cyanocobalamin. So it can lead to paresthesia in long term. It can also lead to a reduction in absorption of calcium that can lead to increased risk of fracture. So option A, blood glucose levels, it makes no sense at all. Option B, thyroid stimulating hormone. Option C, uric acid levels. And option D, vitamin D status. So vitamin D status is somehow indirectly related to calcium levels. Let's see hint. Focus on the nutrient associated with increased risk of fractures and bone health. So vitamin D is the only option. Question number 9 says, what is recommended IV administration procedure for ranitidine? Recommended IV administration procedure for ranitidine. So it should be diluted with normal saline, 0.9% sodium chloride, and given over at least 5 minutes. Option B says dilute in 5% dextrose only. Option C says infuse at rate of 100 milligram per hour over 30 minutes. Option D says give as a rapid undiluted bolus over 1 minute. So we'll see hint, and but according to me, I think option A is the right answer. Safety precaution by for IV ranitidine focus on avoiding rapid administration to prevent cardiac side effects. So in option A, we are giving it over 5 minutes by diluting it with 0.9% sodium chloride, that is normal saline. So I think option A is somehow a better option. It is correct. A patient taking omeprazole 20 milligram daily for GORD reports inadequate symptom control after 4 weeks that it's not sufficient. So 20 milligram is being used. What is the next logical step in oral dosing? Switch immediately to esomeprazole, add nitidine 150 milligram twice daily, increase to 40 milligram once daily for 4 weeks, or decrease to 10 milligram. So increasing dose will work. We have to uh, get that therapy or get the therapy to that point where we can achieve optimum effect by increasing dose. So I would recommend to go for 40 milligram for 4 weeks. It is correct. We have to increase the dose to 40 milligram daily. So here is the end. We can ask for more questions. Let's see what we get. Till now we have 9 out of 10. We have very good results. So now let's go for harder questions. We will do 10 questions. All topics, not growth areas, but all topics. Let's see what we have now. So here are few more difficult questions. A patient is prescribed a proton pump inhibitor along with clopidogrel. Very interesting choice. Based on practice points. Oh, sorry. I have to commit one thing. I told you before that Cimetidine is linked with cytochrome P450 inhibitor, and I think I said CYP2C19. So I actually told you about the cytochrome that is inhibited by omeprazole. Cytochrome P453A4 is actually inhibited by cimetidine. That is also inhibited by azole antifungals. And 3A4 is one of the commonly used cytochrome P450 by many of the drugs for the metabolism. So that's why cimetidine has more drug interactions as compared to omeprazole. Omeprazole blocks cytochrome 2C19, and 2C19 is used by clopidogrel to be converted into active form. So when omeprazole binds and inhibits 2C19, then clopidogrel is not going to be effective because 2C19 causes clopidogrel to be converted into active form. Based on the practice points, which proton pump inhibitor should ideally be avoided due to the theoretical risk of reducing the antiplatelet activity or effect? So esomeprazole and omeprazole both are like each other, so both. So in case patient is having any heart condition and already using clopidogrel, Clopid, Plavix, so in those cases pantoprazole, lansoprazole, rabeprazole are the safe options. That's why most of the time pantoprazole is preferred. An elderly patient has been taking high dose omeprazole for over 2 years, means 40 milligram. It could be BD or it could be OD. They present with muscle weakness and tremors. Which electrolyte abnormality should be investigated first? Okay, so magnesium level also drops, calcium level also drops. So it could be hypocalcemia as well as hypomagnesemia. Hyperkalemia, hypernatremia are other two options. But this time I will, okay, so it says muscle weakness and tremors. So in this case I will go with hypomagnesemia because magnesium has very good effect to relax our muscles. You may have seen magnesium supplements to induce sleep and to relax muscles. There is one very well known brand known as Cramp Ease that is filled with magnesium just to relax our muscles to get relief from muscle cramps. So I will go with hypomagnesemia, that magnesium goes down, and this is the right answer. Question number 13 says a patient with GORD is currently taking nizatidine. They are now prescribed ketoconazole for a fungal infection. Ketoconazole, as I have told you before, that is also 3A4 inhibitor, and nizatidine is one of the H2 blocker that is also 3A4 inhibitor. Why is this combination a concern? So increased risk of nizatidine toxicity, increased risk of hepatotoxicity, reduced clearance of nizatidine, or reduced absorption of ketoconazole. Yes, there is another point regarding absorption of ketoconazole or any azole antifungal, that whenever you use it with any medicine that reduces acid secretion in the stomach, so those drugs are actually going to inhibit the absorption, because azole antifungals require acidic environment to be absorbed in the stomach, and that's why most of the time beverages are preferred to be used as diluent with the ketoconazole or fluconazole or any other azole antifungal. So I'll go with D just because of this point. Let's see what's the hint, and then we go. Consider how changing the pH. Yes, exactly. It's changing pH ketoconazole absorption reduction. When switching a patient from IV ranitidine to oral therapy for healing of peptic ulcer, what is the standard adult dose? Is it 300 milligram twice daily, 150 milligram once daily at bedtime, 75 milligram twice daily, or 150 milligram twice daily? So 300 is the better option, but let me tell you one thing, that H2 inhibitors are preferred to be taken if patient is taking single dose only, then it's preferred to be taken at night, in the evening. Okay, because in the evening there is more acid secretion. Ulcer healing requires a higher total daily dose than maintenance therapy, so it will be 300 milligram twice daily. That's the maximum, but it's wrong. Okay, so 150 milligram twice daily is the right choice. Okay, then a patient, so now two incorrect answers. A patient on long-term proton pump inhibitor therapy develops watery diarrhea and abdominal pain. Which infection is most strongly associated with this medication class in clinical guidelines? It's very simple, because only Clopidogrel difficile is available in our gut. And let me tell you one thing, that how proton pump inhibitors are going to cause Clopidogrel difficile infections. Well, proton pump inhibitors are going to reduce stomach acidity, means stomach pH will be increased, and increased pH will favor bacteria to survive the environment of stomach. As a result, those bacteria will survive and will enter into the intestine that is already having low acidity. And bacteria will survive and will cause infection. So that's why, and that's the mechanism, that's the logic behind Clopidogrel difficile infection. A patient with Zollinger-Ellison Syndrome requires higher dose. Yes, absolutely. Higher dose of pantoprazole according to the guidelines. What is the typical starting oral dose for the condition? High dose, so it can be given BD, 40 milligram BD, but I'm not sure. Hypersecretory condition like Zollinger-Ellison always require higher doses of proton pump inhibitors, whether it is proton pump, omeprazole, esomeprazole, or pantoprazole. Higher doses are actually used. So I will go with 40 milligram. I'm not sure about that. It can be 80 milligram once daily, but I think it's 40 milligram because it comes in 40 milligram tablet. It's wrong. 80 milligram is the right answer. Okay, so 240 milligram is the highest, is the maximum dose that we can give. Three incorrect answers. Let's head towards question number 17. Which of the following is an infrequent adverse effect of H2 antagonist? Infrequent adverse effect of H2 antagonist: that requires monitoring during IV administration, especially hypertension, hypotension, hyperglycemia, and tachycardia. We have observed in one of the MCQ that I think it was ranitidine that yeah ranitidine that was needed to be diluted with normal saline and then administered over 5 minutes. So just to prevent hypertension, I'll go with option A. Oh, it's wrong. Hypotension. Hypotension is specifically listed. Okay, so hypotension is adverse effect. All right. 4 questions wrong in a row. 2. Question number 18. A patient is prescribed lansoprazole 30 milligram. Again, a difficult question because it's linked with dose. How should the patient be advised to take this medication regarding food? It's very interesting question. Let me tell you why. Because dexlansoprazole is one of the medicine that's taken irrespective of the food. That's this point is actually available in Lippincott pharmacology. What about lansoprazole? Take on an empty stomach 30 minutes before food, or B, take immediately after a meal, take with high fat meal to increase absorption, or timing with food does not matter. So for this purpose, because I think dexlansoprazole is the only option that can be taken irrespective of the food, so I will go with, okay, let's show hand. Optimal efficacy depends on the drug reaching the systemic circulation before the peripheral cells are stimulated by a meal. So take on an empty stomach is the right answer. In patients with severe hepatic impairment, which statement regarding proton pump inhibitor dosing is most accurate? Severe hepatic impairment. Let me tell you one thing, in severe hepatic impairment, dose should be reduced. Okay, while H2 receptor antagonist, dose is to be reduced in case of renal impairment. The daily dose of esomeprazole should not exceed 20 mg. Proton pump inhibitors are contraindicated in hepatic failure. Only IV formulations require dose adjustment. A dose reduction is never required for proton pump inhibitors. So dose is actually reduced. Okay, it's not only for IV, so I should go with B. Look for the specific numerical limit mentioned. Okay, esomeprazole in the context of liver disease. So yes, because overall dose, either it is IV or tablet formulation or capsule formulation, dose should be reduced. So it can't be option C that says just IV. No, it says contraindicated in, no, it's not contraindicated in hepatic failure. It is actually all about dose adjustment, means dose should be reduced in case of hepatic failure or hepatic impairment. Dose reduction is never required. Dose reduction is actually required. So option A is the best choice. So these kind of questions you will tackle, that all options will be looking alike, will be looking like all are correct, but you have to choose the best answer. Which H2 antagonist has the lowest amount of clinical experience in pregnancy and is classified as category B3? So H2 antagonist. So it is nizaridine actually. It's very straightforward question. Cimetidine, famotidine, ranitidine are considered safe in pregnancy, but nizaridine has less experience to be checked. So we are done, and 4 wrong questions, and we have score of 16. I have score of 16 out of 20. You may have done better. So this was today's discussion. We will discuss other MCQs later. Till then, goodbye.